Medycznego w Katowicach, profesorów honorowych Śląskiego Uniwersytetu Medycznego w Katowicach oraz rektora Śląskiego Uniwersytetu Medycznego w Katowicach.
Pragnę w imieniu Senatu Śląskiego Uniwersytetu Medycznego w Katowicach i swoim własnym powitać Państwa, powitać dostojnych gości przybyłych na uroczystość nadania tytułu doktora honoris causa panu profesorowi Gregory'owi Lipowi. Witam panie posłanki, panią poseł Barbarę Dziuk i panią poseł Mirosławę Nykiel. Witam zastępczynię dyrektora Departamentu Nadzoru Podmiotów Leczniczych i Ochrony Zdrowia Urzędu Marszałkowskiego Województwa Śląskiego, panią Halinę Czaplę. Witam pana konsula Republiki Chorwacji, prezesa Zarządu Izby Przemysłowo-Handlowej Rybnickiego Okręgu Przemysłowego, pana Andrzeja Żylaka. Witam dyrektora Wojewódzkiej Stacji Sanitarno-Epidemiologicznej w Katowicach Śląskiego Państwowego Wojewódzkiego Inspektora Sanitarnego, pana doktora nauk medycznych Grzegorza Chudzika. Witam komendanta Śląskiego Oddziału Straży Granicznej w Raciborzu, pana generała brygady Adama Jobka. Witam okręgowego inspektora pracy w Katowicach, pana Piotra Kalbrona. Witam przewodniczącego Rady Narodowej Agencji Wymiany Akademickiej, przedstawiciela ministra właściwego do spraw szkolnictwa wyższego i nauki, pana profesora doktora habilitowanego Tomasza Pietrzykowskiego. Witam członkinię Prezydium Naczelnej Rady Lekarskiej, panią profesor Halinę Borgiel-Marek. Witam panią prorektor do spraw dydaktyki i nauki Akademii Medycznej imienia Karola Szymanowskiego w Katowicach, panią profesor doktor habilitowaną Wandę Palacz. Witam panią dyrektor Uniwersyteckiego Centrum Klinicznego w Katowicach, panią Renatę Wachowicz. Witam zastępcę dyrektora do spraw ekonomiczno-administracyjnych Górnośląskiego Centrum Zdrowia Dziecka imienia Świętego Jana Pawła II w Katowicach, panią Marię Szymich-Lukosek. Witam zastępcę dyrektora do spraw lecznictwa Górnośląskiego Centrum Zdrowia Dziecka imienia Świętego Jana Pawła II w Katowicach, pana Roberta Krawczyka. Jeżeli kogoś pominąłem, witam wszystkich przedstawicieli władz samorządowych, parlamentarzystów. Serdecznie witam wszystkich przybyłych na dzisiejszą uroczystość gości. Witam serdecznie profesorów honorowych Śląskiego Uniwersytetu Medycznego w Katowicach, w tym przede wszystkim pana profesora Grzegorza Opale. It's a great pleasure to welcome Professor Gregory Lip with wife, who will be honored with the title of Honorary Doctorate of the Medical University of Silesia in Katowice. You are very welcome. You are the real hero of today. Witam Wysoki Senat. Witam przedstawicieli Rady Dziedziny, Rady Dyscyplin. Widzę pana przewodniczącego, pana profesora Macieja Misiełka, też witam bardzo serdecznie. Witam wszystkich państwa przedstawicieli środowiska akademickiego, profesorów, doktorów, pracowników administracji. To jest nasze wielkie święto. Nie ma większego święta od nadania tytułu doktora honoris causa. Szanowni Państwo, dostojni goście, jestem niezwykle dumny, że dziś tytułem doktora honoris causa uhonorujemy pana profesora Gregory'ego Lipa, nie tylko wybitnego naukowca cieszącego się ogromnym autorytetem w światowym środowisku naukowym i specjalistycznym, szczególnie kardiologicznym, ale pozwolę sobie powiedzieć wielkiego przyjaciela naszej uczelni, współpracującego zarówno w zakresie projektów badawczych, szkoleń specjalistycznych oraz wspierającego z życzliwością młodych naukowców, którzy mogą czerpać z jego wiedzy, doświadczenia podczas staży naukowych w uniwersytetach Birmingham oraz Liverpoolu, korzystając w pełni z relacji uczeń-mistrz, będącej podstawową misją wypełnianą przez uczelnię. W tym miejscu chciałem wspomnieć wieloletnią współpracę pana profesora Lipa, honorowego członka Polskiego Towarzystwa Kardiologicznego z Kliniką i Katedrą Kardiologii Wad Wrodzonych Serca i Elektroterapii Śląskiego Uniwersytetu Medycznego w Śląskim Centrum Chorób Serca w Zabrzu, kierowanej przez pana profesora Zbigniewa Kalorusa, której efektem jest szereg pionierskich publikacji naukowych. To dla społeczności Śląskiego Uniwersytetu Medycznego zaszczyt, że dziś poprzez nadanie panu profesorowi tytułu doktora honoris causa naszego uniwersytetu umocnimy nasze tak wyjątkowe, owocne relacje. Szanowni Państwo, otwieram uroczystość promocji pana profesora Gregory'ego Lipa na doktora honoris causa Śląskiego Uniwersytetu Medycznego w Katowicach. Uchwała nr 44 z roku 2020, tak proszę Państwa, to jest, czekaliśmy 3 lata na to, żebyśmy tę ceremonię mogli odbyć. Uchwała Senatu Śląskiego Uniwersytetu Medycznego w Katowicach z dnia 24 czerwca 2020 roku w sprawie nadania tytułu doktora honoris causa Śląskiego Uniwersytetu Medycznego w Katowicach panu Gregory'emu Lipowi. Na podstawie artykułu 28 ustęp 1 punkt 9 artykułu 34 ustawy, pierwszy punkt 8 ustawy z dnia 20 lipca 2018 roku Prawo o szkolnictwie wyższym i nauce oraz paragrafu 10 ustawy 12 Statutu Śląskiego Uniwersytetu Medycznego w Katowicach w związku z uchwałą nr 10/2020 Rady Dziedziny Naukowej SUM z dnia 9 czerwca 2020 roku w sprawie przyjęcia protokołu końcowego w postępowaniu o nadanie tytułu honorowego doktora honoris causa panu profesorowi Gregory'emu Lipowi i wnioskiem z dnia 2 marca 2020 roku 5 nauczycieli akademickich uczelni posiadających tytuł profesora, Senat Śląskiego Uniwersytetu Medycznego w Katowicach uchwala, co następuje. Nadaje tytuł doktora honoris causa Śląskiego Uniwersytetu Medycznego w Katowicach panu profesorowi Gregory'emu Lipowi. Wnioskodawcami postępowania w sprawie nadania tytułu doktora honoris causa panu profesorowi Gregory'emu Lipowi byli pan profesor doktor habilitowany nauk medycznych Zbigniew Gąsior, pan profesor doktor habilitowany nauk medycznych Zbigniew Kalarus, pani profesor doktor habilitowana nauk medycznych Beata Średniawa, pan profesor doktor habilitowany nauk medycznych Michał Tendera i pan profesor doktor habilitowany nauk medycznych Wojciech Wojakowski. Recenzentami w postępowaniu byli pan profesor doktor habilitowany nauk medycznych Jarosław Kaźmierczak, pan profesor doktor habilitowany nauk medycznych Grzegorz Opolski, pan profesor doktor habilitowany nauk medycznych Tomasz Grodzicki. Teraz proszę o zabranie głosu pana profesora Zbigniewa Kalarusa, promotora postępowania o nadanie tytułu honorowego doktora honoris causa panu profesorowi Gregory'owi Lipowi.
Jego magnificencjo, szanowny panie rektorze, szanowni prorektorzy, członkowie Senatu, szanowni państwo, zostałem prawnie powołany przez Senat Śląskiego Uniwersytetu Medycznego w Katowicach promotorem postępowania o nadanie tytułu honorowego doktora honoris causa panu profesorowi Gregory'emu Lipowi. Szanowni państwo, przygotowałem krótką laudację, ale proszę mi wierzyć, nie było to zadanie takie proste i oczywiste, bo gdybym chciał przedstawić wszystkie osiągnięcia, zakres działania naszego dzisiejszego gościa, zajęłoby to dużo czasu, dlatego pozwolę sobie przedstawić tylko te najważniejsze w moim odczuciu zasługi pana profesora Lipa, który bez wątpienia jest światowym liderem w zakresie szeroko pojętej medycyny sercowo-naczyniowej, a szczególnie w obszarze migotania przedsionków, antykoagulacji. Jest praktykującym kardiologiem, nauczycielem akademickim i badaczem naukowym. Wśród świata tego lekarskiego i nie tylko znany jest przede wszystkim z badań nad epidemiologią migotania przedsionków, patofizjologią choroby zakrzepowo-zatorowej tej arytmii. Jest autorem szeroko stosowanych skal Church-Basque określającej ryzyko udaru mózgu chorych z migotaniem przedsionków czy skali Hasbled, która z kolei służy do oceny ryzyka wystąpienia powikłań krwotocznych. Ale jest również twórcą zintegrowanej opieki nad pacjentami z migotaniem przedsionków, która optymalizuje ich diagnostykę, leczenie, wpływając bez wątpienia na poprawę rokowania, lepszą jakość życia tej ogromnej, liczącej miliony osób populacji chorych. Jego badania skupiają się również na zagadnieniach związanych z naciśnieniem tętniczym, chorobą niedokrwienną serca. Pan profesor Gregory Lip jest absolwentem Uniwersytetu w Glasgow. Ukończył go w roku 1988 i już wtedy uzyskiwał liczne nagrody, wyróżnienia. Został uznany jako the most distinguished graduate in medicine and surgery of the year. Aktualnie kieruje Katedrą Kardiologii Uniwersytet w Liverpoolu. Jest dyrektorem Centrum Współpracy Badawczej Liverpool Center of Cardiovascular Science, które skupia Uniwersytet w Liverpoolu, Liverpool John Moores University oraz Liverpool Heart and Chest Hospital. Dodatkowe afiliacje wymienię tylko część. Wcześniej pracował i kierował Departamentem Kardiologii w Uniwersytecie w Birmingham. Ma afiliację jako profesor wizytujący w Birmingham, to już mówiłem, honorowym profesorem Uniwersytetu w Pekinie w Chinach, wizytującym profesorem Uniwersytetu w Leeds w Wielkiej Brytanii. Kolejne to Instytut Diabetologii w Melbourne w Australii, profesor wizytujący Uniwersytetu w Belgradzie w Serbii, w Tajwanie, kolejny uniwersytet w Nanjing w Chinach, honorowy profesor Ganzhou w Chinach, honorowy profesor Uniwersytetu w Pekinie, w Tajlandii. To tylko część jego aktywności, afiliacji, jakie posiada, jakie uzyskał na przestrzeni minionych lat. Jest poza tym profesorem wizytującym naszego Uniwersytetu, Śląskiego Uniwersytetu Medycznego. Dorobek naukowy, aktywności lekarskie, działania w obszarach prac w towarzystwach naukowych są również imponujące. Jest współautorem licznych międzynarodowych wytycznych, stanowisk eksperckich, w tym takich towarzystw naukowych jak Europejskie Towarzystwo Kardiologiczne, Sekcja Rytmu Serca Europejskiego Towarzystwa Kardiologicznego, American College of Chest Physicians, Towarzystwo Zaburzeń Rytmu Azjatyckiego, pełni funkcję redaktora naczelnego wielu międzynarodowych czasopism, króciutko to przedstawi. Jest edytorem in chief prestiżowego magazynu Thrombosis and Hemostasis. Gościnnym edytorem Circulation American Heart Journal, Associated Editor Europe's Cerebrovascular Diseases. Jest członkiem komitetów naukowych, komitetów piszących, wielu towarzystw naukowych. Szanowni Państwo, nie będę ich wszystkich wymieniał. Jego dorobek naukowy jest imponujący. Króciutko przedstawię te liczby. Jest autorem imponującej liczby publikacji, ponad 3700. Publikacji naukowych, które głównie dotyczą obszarów, o których wspomniałem, migotania przedsionków, nadciśnienia, antykoagulacji. Wskaźnik cytowań, indeks Hirscha jest imponujący, bo wynosi 240, a indeks cytowań jest bardzo wysoki. W uznaniu swoich osiągnięć naukowych otrzymał wiele nagród, wiele wyróżnień, w tym medal Europejskiego Towarzystwa Kardiologicznego, nagrodę American College of Cardiology za rok 2023. Jest nominowany jako doktor honoris causa w licznych uniwersytetach, również w naszym. To Uniwersytet Aalborg w Danii, Uniwersytet w Bukareszcie w Rumunii, w Belgradzie, Uniwersytet w Belgradzie w Serbii, Uniwersytet we Francji, Uniwersytet de Tours, oczywiście nasz uniwersytet i Uniwersytet w Modenie we Włoszech. Krótko przedstawiłem charakterystykę, część osiągnięć, dokonań profesora Lipa. Powtórzę jeszcze raz, jest nie tylko wybitnym naukowcem, ale lekarzem, nauczycielem akademickim. Możemy stwierdzić, że zapewne większość lekarzy na świecie, nie tylko kardiolodzy, interniści czy lekarze rodzinni, wiedzą, kto to jest profesor Lip i to nie tylko wynikając z tego, że jest twórcą skali Czas-Wask, którą wszyscy stosujemy. Jest przyjacielem wspierającym polskie środowisko lekarskie. Gościł wielokrotnie na kongresach, konferencjach polskich towarzystw naukowych, w tym wielokrotnie w kongresach Polskiego Towarzystwa Kardiologicznego. Jest członkiem honorowym tego towarzystwa. Współpracuje, o czym mówił jego magnificencja rektor, z naszym uniwersytetem już od wielu lat. Wielu naszych młodszych adeptów z kardiologii miało możliwość odbycia staży naukowych kierowanym przez pana profesora Lipa jednostkach. To skutkuje ich rozwojem naukowym, uzyskiwaniem kolejnych stopni naukowych. Jego wsparcie w tym obszarze, zarówno naukowe, ale chcę podkreślić również i organizacyjne, jest bezcenne i z tej okazji chciałem panie profesorze, panu podziękować za całokształt i głęboko wierzę, że nasza współpraca będzie toczyć się dalej. Bardzo państwu dziękuję.
Bardzo dziękuję panu profesorowi, panu promotorowi za tą piękną laudację. A teraz proszę panią rektor, prorektor do spraw nauki i współpracy międzynarodowej, panią profesor doktor habilitowaną nauk medycznych Katarzynę Mizię-Stec o odczytanie tekstu dyplomu, a państwa proszę o powstanie.
Quod felix Faustum fortunam quesit, sumis auspicis serenissime rei publice Polonorum, nos Tomasz Szczepański, doctor medicarum scientiarum, professor pediatrie, hematologie et oncologie infantilis, Silesiensis Universitatis Medice Katowice, rector, et Andras Więcek, doctor medicarum scientiarum, professor nefrologie, Silesiensis Universitatis Medice Katowice, prezes concilii discipline, et Zbigniew Skalarus, doctor medicarum scientiarum, professor cardiologie, Silesiensis Universitatis Medice Katowice, promotor rite constitutus, in dominum Gregory'us Lipow. Ecce eminens vir doctus, cardiologus, in scala mundana homo peritus, cordis arythmie, fibrillationis atriorum, terapie anticoagulantis, hypertensionis arterialis, ictus cerebrique. Is studia medica in Universitate Glasgowensi millesimo nongentesimo octogesimo octavo anno absolvit, postquam princeps instituti cardiovascularium scientiarum in Universitate Birminghamensi fuit, et director Liserpaliensis cardiovascularium scientiarum centri in Universitate Liserpali est. Is director nationalis sanitatis investigationis instituti est, et questiones ad fibrillationis atriorum administrationem agit. Is eminens vir doctos est, et numerus eius publicationum supra 2.000.000 nongentas est, atque H index gravis, et ad numerum centrum nonaginta tria est. Is activum multorum corporum Europae Societatis Cardiologiae membrum, in his associationis rhythmus cardialis echra est. Qui viro ab Universitate in Aalborg in Dania, Bucarestieni Universitate Medica, Universitatie Singudini et Universitatie Turonensi in Gallia, titulus doctoris honoris causa latus est. Is honorabilis atque visitans professor in multis universitationis in mundo, et bis millesimo undevicesimo anno etiam visitans professor in Silesiensi Universitate Medica Katowice est. Is coauctor decem elaboratarum normarum et opinionum hominum Europae Societatis Cardiologiae, peritorum hypertensionis arterialis, fibrillationis atriorum et terapie anticoagulantis est, presidens quinque hominum peritorum gregibus. Is creator Charles Vask et Hasblet periculi scalarum, que generatim in usu clinico adhibitionem habent est. Editor generalis autoritativi thrombosis et hemostasis diari est. Multis annis cum cardiologis polonicis cooperatus est, et in congressibus Polonice Societatis Cardiologiae frequenter antiquae participatus est. Titulus honorabilis membri Polonice Societatis Cardiologiae bis 1710 anno ei tributus est. Consulto Senatus Silesiensis Universitatis Medice Katowice, die 24 mensis Juni bis 1010 anno. Titulum Doctor Honoris Causa, atque honores, jura et privilegia, et aum titulum pertinentes conferimus, et hasce litteras sigillo confirmamus. Datum Katowice, die 17 mensis Mai, bis 1013 anno. Tomasz Szczepański, rektor, Andras Więcek, prezes, Zbigniew Kalarus, promotor. Dziękuję bardzo. Bardzo proszę Jego Magnificencję rektora o dokonanie aktu promocji, wręczenie dyplomu doktora honoris causa oraz szarfy panu profesorowi Gregory'emu Lipowi.
Gaude Mater Polonia, one of the most beautiful congratulation Polish song. And now it's time for Professor Gregory Lip to address the participants of the ceremony. The floor is yours.
Well, I'm not very often speechless, but thank you again, Rector, Vice Rectors, Senate, distinguished guests, friends, colleagues, fellows who have been associated with our collaboration, ladies and gentlemen. So it really has been a great honor. I feel very humbled. I feel very grateful and honored by this conferment of the Doctor Honoris Causa. I'm also given the opportunity to deliver a presentation, a lecture on a doctoral presentation. I've chosen the title of Atrial Fibrillation and Stroke Prevention, which as highlighted by my good friend, collaborator, Professor Honoris, has been very much my work for the many last decades. And I'd like to take you through on a bit of a journey with regard to the past, the present, and the future with regard to atrial fibrillation and stroke. So, firstly, what of course is atrial fibrillation? I think it's just to be, for our audience, this is the commonest cardiac rhythm disorder. And here we have the situation where we have the irregularity of the heart rhythm resulting in the upper chambers, the atria, therefore causing the uncoordinated activity leading on to stasis. And why is this important? Because if we're adults in this room, age 40 and above, have a 1 in 4 lifetime risk of developing atrial fibrillation. And if in our lifetime we're lucky enough not to sustain a heart attack or heart failure, the lifetime risk is still 1 in 6. So we're talking about something extremely common. Now, this is not a new condition, because if you turn to history, and this is just an animation showing that on the left, that's the normal heart rhythm, where it's nice and coordinated between the atria and the ventricle. In contrast, on the right, as you can see, with atrial fibrillation, the top chamber is irregular, therefore leading on to stasis and the formation of clot, and therefore leading on to stroke. Atrial fibrillation, of course, has its own, because it's a less efficient cardiac rhythm disorder, pumping action is therefore reduced, leading on to heart failure. So this is not a new condition, because if you turn through the history books, looking at the past history of atrial fibrillation, if you look through to Huang Ti, which is between 2000 BC, his classic of internal medicine, and to the cardiologists in the audience, this is the Braunwald's cardiology of 2000 BC. And you can see this phrase here: when the pulse is irregular and tremulous and the beats occur at intervals, the impulse of life fades. When the pulse is slender, smaller than feeble but still perceptible, thin like a silk thread, then the impulse of life is small. And you can say that almost sums up a nice description of atrial fibrillation, even back in ancient times, that this condition is recognized. The link between atrial fibrillation and some of the more contemporary complications of atrial fibrillation, like heart failure, is illustrated by this man, who is William Withering. Now, as you've heard in Professor Honoris' presentation, I previously worked in Birmingham. Now, William Withering was a general physician in Birmingham, and he had noticed or known that there was a herbal remedy from a lady in Shropshire for the treatment of the dropsy, which nowadays we recognize as heart failure. And the active ingredient in this treatment, this herbal treatment, was actually Digitalis purpura, and that's him holding the purple foxglove there. And we know from that with Digitalis purpura, of course, it contains the cardiac glycoside digitoxin. Now, today's use of digoxin Well, that's not from the purple foxglove, that's from digitalis lanata, but that's the connection again, because many of the patients with heart failure had associated atrial fibrillation, and the pulse was also noticed to be erratic and irregular, and the fact that there was digitalis or digitoxin in the purple foxglove, this is what helped treatment of heart failure due to the inotropic effects, as well as the regularization of patients with heart failure with atrial fibrillation. So, to the topic that I will focus on is obviously the risk of stroke. And you could almost say that the first priority in atrial fibrillation management for many, many years now is stroke prevention. And as you see with atrial fibrillation, it leads on to stroke. So the direction going on to developing strokes. And why is that relevant? Because the fact that atrial fibrillation exists, and if a stroke occurs, the risk of recurrent stroke is substantially increased, and patients with atrial fibrillation who sustain a stroke have a greater mortality, greater risk of rehospitalization, longer hospital stays, a greater disability, lower rate of discharge back to independence in their own homes. Numerous studies have looked at this, and this is one example. This is an Italian population-based study, and on the top right here you can see how with recurrent stroke, how atrial fibrillation increases that risk. Perhaps more importantly is here, you see patients with atrial fibrillation in red, patients without atrial fibrillation in blue. You will see at 1 year, 50% mortality rate in the presence of atrial fibrillation compared to the patients without atrial fibrillation, which is just under 30%. So this increase in recurrent stroke, increase in the risk of mortality, hence this burden associated with atrial fibrillation and atrial fibrillation-related complications. And to put this in perspective, so let me introduce something called framing, the magnitude of what we're dealing with. Now, there are some who will recall in 2004, there was a major natural disaster in Southeast Asia in the Aceh province in Indonesia, and this was a tsunami which occurred on Boxing Day. This is, as mentioned, a great natural disaster. And as you can see in the top left is the Boxing Day tsunami which hit Aceh province. And as a result of this great natural disaster, there were, mortality was 25% within 30 days. Injured and disabled was 10%. Now, if you frame this in the context of atrial fibrillation without anticoagulation, you will see here that mortality in red is 25%, dark red. In pink here, you will see disability about 50%. And if you have patients with atrial fibrillation who are anticoagulated, at the bottom, mortality is now 9%, and disability is reduced at 40-odd%. So this is putting into framing this burden or this problem in relation to one of the big natural disasters that occurred in that part of the world. And you could actually refer, and in our publication, we refer to this as a atrial fibrillation-related stroke tsunami. But given that in the management of heart conditions, we're getting better at managing myocardial infarction, we're getting better at managing heart failure, what we are actually seeing is an emerging epidemic of atrial fibrillation. And this is no big surprise, leading to a greater prevalence, a greater incidence of patients with atrial fibrillation. There are more survivors of heart attacks. They have clearly impaired cardiac function, therefore leading on to more atrial fibrillation. And this drives healthcare costs. And this is an analysis that we did for UK data. And you will see that depending on the projections with regard to the cost of atrial fibrillation in blue, if there was a projected 3% increase, in orange a 4% increase, or in gray a 6% increase, look at the costs related to AF between 2010 and 2040, how this is almost exponentially increasing. And as you will see on the pie chart, the biggest chunk of the cost pertains to hospitalizations. And if we are in healthcare systems, And UK, and perhaps you could say Poland's no exception, where healthcare costs are a major issue. You can see how the burden associated with hospitalizations, associated with atrial fibrillation and atrial fibrillation-related complications, if anything, we're going to see more of this. So why this epidemic of atrial fibrillation? So why this risk of more and more atrial fibrillation? Yes, we're getting better at managing some of the acute cardiac problems. What about other lifestyle type issues? And I'll start off by mentioning obesity. Now, atrial fibrillation is not unique to Europe. This is a global problem. This is a global arrhythmia. And this is a study we recently published comparing and looking at body mass index and obesity in Korea and United Kingdom. So Asian data, European data. And what you can very nicely see is this increasing risk of atrial fibrillation. This is the UK data, and at the bottom in blue are the Asian data. And this is the risk of atrial fibrillation in relation to waist circumference. Again, you see the same parallel. So, and without necessarily going into the detail, the take-home message is the fact that if obesity is becoming a problem globally, what we're seeing is overweightness and obesity are associated with this increase in age-adjusted atrial fibrillation incidence, whether you're looking at Asian data, whether you're looking at UK data. So it's this comparative epidemiology between different parts of the world. Now, obesity is not a yes-no diagnosis. And this is where we look at some of the associated metabolic abnormalities associated with obesity. And this is this concept of metabolically healthy obese and the metabolically unhealthy obese. Now, these are French data, and what you will see here in blue are the non-obese, in red are the obese. So, as mentioned, this is obesity, it's not a yes-no diagnosis. So what we then divided is in relation to the metabolic abnormalities of diabetes, hypertension, and hyperlipidemia. I think it's pretty clear in relation to the new onset atrial fibrillation, there's graded increase in risk from the non-obese, no metabolic abnormalities, non-obese with additional metabolic abnormalities, obese with further increases in metabolically abnormal metabolic abnormalities like diabetes, hypertension, hyperlipidemia, how the worst outcomes are the obese and are metabolically unhealthy, where you see this almost 68% increased risk or hazard of new onset atrial fibrillation. That doesn't just apply to overt hypertension or overt diabetes or overt obesity. So here we're looking now, and this is data we only recently published, look at patients with high normal blood pressure. So even just what you would regard as just, within the top range of normality. Hypertension is also not a yes-no diagnosis. Diabetes is not necessarily a yes-no diagnosis, because in here we are looking at impaired fasting glycemia. And compared to no risk factor as the baseline, and if you're looking at a single risk factor, how the risk is increased. If you have two risk factors, it's increasing even more. And with three of these risk factors combining high normal blood pressure, impaired fasting glycemia, and also body mass index above 25, that's when the risk of developing new onset atrial fibrillation is by this combination of risk factors. And hopefully that makes sense, because for many, when we analyze risk factors, we have a tendency to look at a risk factor in a binary manner, yes and no. The reality is, if you think about certain risk factors, they occur in combination. They occur in clusters. And let me give you a quick example. Atrial fibrillation, and we want to understand the impact of diabetes. So what do? We analyze diabetes yes versus AF with diabetes no. And that's really a simplification, because our atrial fibrillation patients with diabetes very often will have kidney disease, vascular disease, heart failure, and so on and so on. And all those have competing impacts on the outcomes related to atrial fibrillation that are clinically relevant, that we need to improve the management. And as an example, diabetes patients. And if you look at hypertension, and it's not just hypertension at the baseline, it's looking at the burden of hypertension over the follow-up period. I think it's pretty convincing if you look at it in quartiles, or you look at it in tertiles, in deciles, I mean, you can see how this risk correspondingly goes up over time. The Kaplan-Meier curve nicely shows this increasing burden associated with atrial fibrillation, where you have this combination of risk changing over time in these patients who have underlying diabetes and the impact on developing atrial fibrillation. So just to introduce this concept of risk factor burden. And risk factor burden is not just the risk factors that you and I traditionally would manage in the clinic. This is on top of the genetic predisposition that, rather unfortunately, we can't necessarily manipulate, but it's just to say that there is still this epigenetic phenomenon. This is data we published from UK Biobank. As you can see, a large cohort there. And if you're looking at the accumulation of risk factors, no big surprise in the blue is the patients with elevated risk factor burden compared to the borderline or the optimal burden on top of genetic predisposition using a polygenic risk score, how these patients had the highest 10-year risk of atrial fibrillation. But as mentioned, genetics may not be so easy for us to actually intervene. So what can we actually intervene? So we examined this because the reality is if we manage a patient with atrial fibrillation in our clinic, they very often have multiple risk factors or multiple comorbidities, so-called concept of multimorbidity. And that's a real problem because look at the left here. These are data, this is a large Italian cohort looking at data between 2002 and 2014. And in the non-AF patients, that's the light blue, you will see this over time, multimorbidity as reflected by the Charlson Comorbidity Index is increasing. And that's no big surprise because we said before the general population is aging, we're getting better at managing acute heart problems like heart attacks, and we're getting improving our care of patients with heart failure, for example. So multimorbidity increasing in the non-AF population. Look here for the AF population. This is the mean Charlson Comorbidity Index. A very steep increase such that by 2014, how the multimorbidity as reflected by the mean Charlson Comorbidity Index is substantially higher compared to the non-atrial fibrillation patients. But the implications of that, because if you compare the atrial fibrillation patients who have high multimorbidity compared to those who have low or moderate multimorbidity, higher risk of stroke, higher risk of bleeding, higher risk of mortality. And while that increase in risk is pretty clear from the data there, paradoxically, giving evidence-based treatment, which is anticoagulation, is inverse to the fact that these patients have a higher risk. So higher multimorbidity, higher risk, and what do we see? Less anticoagulation treatment in these high-risk patients. And atrial fibrillation patients is, you could say atrial fibrillation is more common in the elderly, and with elderly, that's the, again, association with frailty. And we looked at this in relation to the risk, to the prevalence of frailty in patients with atrial fibrillation, about 40%, even pre-frailty, 35%. And no big surprise, like multimorbidity, the presence of frailty, higher mortality, higher risk of stroke, higher risk of bleeding. And the paradox is there, anticoagulation under-prescribing. This is despite this very high risk in these patients. So we need to move in a sense, and this is a concept during the course of my presentation, that we tend to, rather than focus on just one bit of the patient, we manage the whole patient, not just in a holistic manner. Back to this clustering of comorbidities. And this is something we've been quite interested in. This is data from Europe, the ESC EORP, European Observational Research Program, AF registry. And this is a methodology-used cluster analysis. So what you can do is you can look at the common clustering of common risk factors that all sit together. And in this analysis, large cohort, well over 10,000 patients, you can cluster into the low-risk cluster, which is green. There's the red in non-cardiac comorbidities, and finally cluster 3, the very cardiovascular risk factor and the comorbidities. And that translates to differences in outcomes. For example, cardiovascular events, no big surprise, highest risk in cluster 3. You're looking here at mortality, same pattern, and then the composite outcome of cardiovascular mortality, cardiovascular death, and major adverse cardiac events. But these risk factors that cluster leads to this clinical complexity syndrome in patients with atrial fibrillation. And here are the detail with regard to the increased hazard risk. You see cluster 3, the cardiovascular, nearly threefold or more increase in cardiovascular events or in all-cause mortality, and the composite outcome. So I think it's important, again, that we need to make a difference in doing something with these patients. But these clinical complexity patients, you see this in different populations. This is a composite result slide from data from the Gloria registry and EORP. Frail patients, chronic kidney disease patients, history of bleeding, and the combination. And if you look at the adverse clinical outcomes, I think you see consistency. Whether you look at a global registry, whether you look at the European registry, you see the same pattern of clinical complexity leading to worse outcomes. But the same paradox is there, less prescribed in the clinical complex patients, and then even if they are prescribed anticoagulation treatment, the risk of discontinuation is substantially higher. So this is setting the scene on why atrial fibrillation has been a major medical problem, why it's a public health problem, why it's a population-based epidemiology you could say, tsunami. So what can we do about this? Well, if you turn to any textbook of medicine and you look at the section on atrial fibrillation, what does it cover? It covers stroke prevention. It covers the management of the symptoms with controlling the heart rate or controlling the rhythm, controlling the atrial fibrillation, and then managing of the comorbidities. So in the real world, because atrial fibrillation is so common, it's not managed by only cardiologists. They're managed by general practitioners. They're managed by internal medicine. They're managed in the emergency room. They're managed in the stroke department. You can see how it's so important to get a holistic and simple approach across the whole spectrum of managing these patients with atrial fibrillation. But even before the patient takes these steps, you've got to improve the detection of atrial fibrillation. And this, you could say, is summed up in current guidelines. This is the European guidelines. The 250 pages from the European guidelines can be summed up as this CC to ABC. What is the C? You confirm the diagnosis, you detect the atrial fibrillation. Here you characterize atrial fibrillation in terms of stroke risk, symptoms, severity of burden, and substrate. And particularly substrate relates to aging as well as the comorbidities. Then after you've done the CC, you treat atrial fibrillation, and this is the so-called ABC pathway. I'll come back to this later in the presentation, but A is for anticoagulation, or A is avoiding a stroke. B is better symptom control with patient-centered, symptom-directed decisions on rate and rhythm control. And finally, the C is the cardiovascular and comorbidity management, including lifestyle-type changes. That's the CC to the ABC in the guidelines. And let's start off with the C, screening and detection. Why the focus on this? Because if we're going to make a difference on the population basis in relation to atrial fibrillation and the public health and healthcare cost impact, we have to pick up more atrial fibrillation. So this is an analysis looking at UK data between 2020 and 2030. And I think this is looking at cost savings if you have atrial fibrillation screening and treatment of atrial fibrillation will have an impact in relation to particularly atrial fibrillation related costs, whether you, depending on your scenario, whether you target only the high-risk population or you screen all the 65-year-olds. Well, I think you're going to see that in terms of the potential costs associated with this and the reduction in stroke cases due to atrial fibrillation screening, I think you can see how the impact is going to be substantial. Now, this is not, as I mentioned, only a UK problem. We see this, of course, in Poland. This is the NOMAD AF study, because I think the fact that we are dealing with something that is so common, excuse me, so common and often asymptomatic is to try and work out easy and innovative ways to pick up atrial fibrillation. And in NOMAD, this was one collaboration with my good friend, Professor Carl Roos, is using this vest to where the individual could wear this and pick up atrial fibrillation. And this is looking at projections between 2015 and 2055 for men and women. I think you're going to see more and more the Polish population is going to have more atrial fibrillation. And I think this is detected all atrial fibrillation. Look at silent atrial fibrillation. I think you can see this increase over the time period as well. But if you look at high-risk groups, this is the diabetic subgroup of, from the NOMAD AF study. Atrial fibrillation affects, again, 1 in 4 of the subjects with concomitant diabetes. And I think you see this age dependency here. In blue are the patients who with diabetes compared to those in orange without diabetes. But look at the symptomatic status. I think the asymptomatic or silent atrial fibrillation is also substantial in this particular cohort. So I think we're dealing, as hopefully convinced all of you, this is a big epidemiological problem that we need to address. Now, innovative ways to screen for atrial fibrillation. I just thought I'll show this. It's something we did in Liverpool. One of our colleagues, Ian Jones, is a professor of cardiovascular nursing, and there is something which looks like a stick. It's called My Diagnostic that you can use and hold it with your hand to screen for atrial fibrillation. So Ian Jones put it into the supermarket trolley handle, and therefore these subjects who went shopping in the local supermarket, pushing the trolley, this is where they were screened for associated atrial fibrillation. And it worked in a sense that it's, as long as you take the consent from the patient, this is where you pick up atrial fibrillation in the community. But the work goes on. There are challenges remaining globally. This is our global health project looking at atrial fibrillation in Sri Lanka, Brazil, and rural China. Here are some of the analyses with regard to barriers and facilitators to care. And we again assume that we can deliver best care, and that may well be in the centers for cardiac excellence. This is an ongoing project in rural China, and we're talking seriously rural here because their main healthcare provider is the village doctors. Now, that's the politically correct term for them now, because they used to be called barefoot doctors, because you could almost say that they're almost like a glorified first aider. It is very basic medical provision of care right in the villages. We are running the SAFER trial. This is the largest cluster randomized trial for screening for atrial fibrillation over 70, with the objective to show that how screening leads to a reduction in overall stroke in the population. Awareness is also important, and I think these are campaigns. The AF Association, Know Your Pulse, simple advice on the risk of atrial fibrillation, encouraging and teaching the public to feel their pulse. There's the awareness weeks there, and obviously should a stroke occur, how to improve the early presentation with regard to stroke-based therapies. This is a community engagement event that we did. This is called the University of the Third Age. The mean age of the population of the people in the room there was about 85. So we were just encouraging and teaching them how to feel a pulse, and we also use an alive call to pick up atrial fibrillation in this group of patients. So, turning to the management, what's the difference? How can we make a difference? So let's focus on stroke prevention. And before you initiate treatment with anticoagulation, you need to assess risk. And with terms of stroke risk assessment, and the CHADS-VAS score was previously mentioned, well, keep it simple, keep it practical, because risk scores, and CHADS-VAS is no exception, they are mere simplifications to help the decision-making. These clinical risk scores have modest predictive value for identifying the high-risk patients, and of course, there are more and more complicated risk scores. They marginally improve in prediction, but statistical significance is not the same as clinical significance. And as I'll show, risk is not static, risk is dynamic. And therefore, to focus on risk factors rather than this artificial low, moderate, high risk categorization, because we look after patients. How often do our patients sit in 3 little neat boxes? They don't. There's a whole spectrum of risk that changes. So here's the CHADS-VAS score. I think in the interest of time, I'm not necessarily going to go through all the acronyms. It's designed, it wasn't designed to include every conceivable stroke risk factor for in atrial fibrillation, because there's many of those. It's to get the more common and the more validated stroke risk factors into something that could be used in everyday practice. Why is it a simplification? Let me just illustrate this. Age is a powerful driver of stroke risk. So you see age 65 to 74 gets 1 point, 75 and above gets 2 points. But it's just common sense. A man with atrial fibrillation age 65 is going to be substantially lower risk than a man with atrial fibrillation age 74, and they both get 1 point. So again, this is a simplification. And just because your patient is 74 years old and 11 months, comes to your clinic, gets 1 point, come back to your clinic 4 weeks later, becomes 75, he gets 2 points. But it doesn't mean that the risk suddenly doubles. It doesn't work like this, because it's mere simplification of the common stroke risk factors available into helping decision making. Now, the CHADS-VAS score, although the publication is 2010, it actually goes back beyond that. In 1997, this book was published, and this was the algorithm in relation to stroke risk stratification. I think that at that time, algorithms were very much in favor, but if you look at the algorithm, you can see CHADS-VAS literally between there, how risk was stratified. And in terms of the treatment, the low-risk patients, CHADS-VAS of 0, no antithrombotic therapy is indicated. So this is something going back to what was referred to as the Birmingham schema, published in 1997. But back to risk factors for stroke and AF. We have tended to look at a risk factor at one time point. We look at an outcome 5 years later or 10 years later. But of course, what happens in the 5 and 10 years later? Patients get older, they get new comorbidities, they get new risk factors. And this is an example. This is from the Taiwan registries. This is looking at patients initially low risk. CHADS-VAS score 0 in males and 1 in females. But what you'll see over time is the acquisition of 1 or more comorbidities over time. The steepest is for hypertension in blue. And then you see here in yellow for heart failure. Then, of course, in red here for diabetes, then vascular disease. So, in fact, in patients who were initially deemed to have no risk factors or low risk at baseline, approximately 4 to 6 months after their initial diagnosis, they would acquire 1 or more comorbidities. What's the take-home message? Risk is not static. Risk is dynamic. Always reassess your patient for their stroke risk. And this is now in the guidelines internationally for patients with atrial fibrillation. And in terms of the implications of that, because people have tended to use the CHADS-VAS score at one time point and looking at the risk of stroke 5 years later. So what we did here was to analyze the baseline CHADS-VAS, the follow-up CHADS-VAS, and then the change in their stroke risk profile. And I'll call that the delta CHADS-VAS, the change in the risk factor profile. And then you see in terms of the prediction, the highest prediction, the best prediction is for the delta CHADS-VAS. So stroke risk is dynamic. Dynamic changes in stroke risk drives the potential for risk. And look at the clinical implications here. These are the patients who sustain a stroke during follow-up. The majority showed a change in their stroke risk profile. Those who didn't sustain a stroke, there's a big chunk where their risk factor profile stays static. Now, this, of course, what I've showed is what is possible in everyday practice, and I suppose it's worth highlighting what the future might bring, because with dynamic stroke risk stratification, looking at changes almost sequentially and daily over time with risk factors, and this brings in the dynamic risk prediction using machine learning and artificial intelligence. No big surprise, the machine learning and artificial intelligence outperform simple clinical risk stratification. So these are our data here using a administrative data set, and you'll see how the C index is just about 0.9, almost perfect prediction for assessing stroke risk using machine learning. So, given all the limitations of stroke risk assessment that I mentioned based on clinical scores, let's make it simple, easy. The default is stroke prevention unless they're low risk. And I don't really know how more simple can I make that. General practitioners can actually apply that. Non-cardiologists can apply that. The default is stroke prevention unless they are low risk. Stroke prevention means anticoagulation, whether with warfarin with a good time therapeutic range, or ideally these days a non-vitamin K antagonist oral anticoagulant. And that's in the guidelines. This is the European Society of Cardiology guidelines. The first step is identify the low-risk patients. It's not the old-style, old-fashioned, many limitations, low, moderate risk type categorization. Identify your low-risk patients, no antithrombotic therapy. Step 2 is to offer stroke prevention to patients with one or more stroke risk factors. And finally, step 3 is to make your choice of anticoagulant, and the default or the preference is with a NOAC. Now, we mentioned bleeding risk earlier, and bleeding risk is there. It's very often misused by the ill-informed, you could say, because bleeding risk assessment is to address the modifiable bleeding risk factors. Then you flag up the high bleeding risk patients for early review and follow-up. And a high bleeding risk assessment score is not an excuse to withhold anticoagulation. And this is a systematic review from PCORI. This is evidence appraisal. And they concluded that the Hasblat score is the score which was first proposed by ourselves in 2010, was the best prediction for bleeding risk. But more importantly, it's the only bleeding risk score that has randomized trial evidence to actually back it up. This is the MARFA-2 trial, a cluster randomized trial. Patients were randomized to usual care clusters or intervention clusters where the Hasblat score was used to mitigate bleeding risk factors and to arrange follow-up. I think it's pretty clear. This is the intervention arm clusters, usual care here. Major bleeding in the usual care is 4.3%. Major bleeding in the intervention was 2%, and therefore less risk of bleeding. If you look at anticoagulation, there was a decline in the usual care, consistent in many cohort studies, anticoagulation declining over time. In the intervention arm, where you use and mitigate, you use the Hasblat score, you mitigate bleeding risk factors, you follow them up properly, anticoagulation actually increased from 63% to 70%. So it's the one bleeding risk score that has actually been tested in a prospective cluster randomized trial. So this was our trial that we conducted using, again, mobile health AF app intervention to optimize structured care for AF patients. So turning to the B and the C of the ABC pathway. So, and it's just to highlight the big interest recently in the B, which is particularly patient-centered, symptom-directed decisions on rate and rhythm control. And that's not a new story. There have been many trials comparing rate control and rhythm control, and this is one of a number of meta-analyses and systematic reviews. And I show this just to say that if you look at the major outcomes of mortality, myocardial infarction, and my topic is stroke, they're all stunningly negative from the historical trials. So why are we talking about it? Well, it's this trial that has brought the focus again. It's called the EAST AF trial, which compared the strategy of usual care to intervention which was based on early rhythm control. And the overall trial, a 21% advantage in favor of early rhythm control compared to usual care. And if you look at stroke, this was about a third reduced in favor of early rhythm control compared to usual care. But it doesn't mean that, we go out and start doing rhythm control and catheter ablation on newly diagnosed, totally asymptomatic, multimorbid 95-year-olds. I think you need a bit of patient selection, because in the early rhythm control arm, the patients actually had more medical contact, they had more optimization of risk factors, etc. And indeed, this impact on stroke is translatable to real-world practice. We published this in JACC EP recently, and this is the patients with a prior stroke and therefore highest risk of a recurrent stroke. And to cut a long story short, the use of early rhythm control for AF patients within their first year of the diagnosis, this translated to a 28% reduction in the risk of recurrent stroke. So selected patients, if you actually act on the rhythm, the patients actually do better. But if you look through what the real-world practice tells us, well, yes, you see this pattern in other parts of the world. This is from Taiwan. You see early rhythm control compared to usual care, reduction in stroke, as well as heart failure, cardiac events, mortality, and adverse events. But if you see, most of the effect was seen in the first 3 months after their diagnosis. So the earlier the better. Choose your patients for early rhythm control. Younger patients do better. Less structural heart disease do better. So in that sense, let's turn to cardiovascular risks and comorbidities, because I mentioned earlier about the impact of obesity and hypertension. Well, it goes beyond that. That's the lifestyle factors. And exercise, smoking, drinking. And here you see some data looking at new onset atrial fibrillation. And going from left to right, these patients become more unhealthy. Less exercise, smoking, drinking lots. And I think you can see the hazard ratio for developing atrial fibrillation is worse with the clustering of unhealthy lifestyle factors. And the converse happens, because if you're looking at unhealthy lifestyle behaviors and the risk of adverse events in the patients with atrial fibrillation, that relationship is there. This is major adverse cardiovascular events. A score of 0 is the unhealthy people. And this is 1, 2, 3 are additional healthy lifestyle behaviors. And I think you can see this relationship that the patients with healthy lifestyle do better. And you see this relationship for stroke as well as heart failure, as well as mortality. So impacting stroke is not just anticoagulation. There's also the rhythm control. There's also the healthy lifestyle behaviors and the comorbidities. And the interaction between the B and the C is evident here. We published this looking at patients with atrial fibrillation and diabetes. We looked at early rhythm control, and I'm focusing on stroke. You see this reduction in stroke by early rhythm control. You also see this reduction in stroke with healthy lifestyle management. And if you look at the combination, you see this graded response. That is healthy lifestyle, that is early rhythm control, and the combination results in the best. So we move away from just the isolated anticoagulation and stroke reduction, and that's it. No, you use everything in combination. But we still have to deal with this residual risk for despite anticoagulation. And this, we assume we anticoagulate, we've done our job, and the answer is we haven't, because despite anticoagulation, the risk of stroke, mortality, cardiovascular events is still substantial. So we still need to make a difference. Or you could put it another way, our work never ends as a physician. We've still got more things to do. We assume we anticoagulate, that's the end of it. No, there's lots more to do as well. And let's turn to how AF care is developed. So this is the traditional model. Because we're dealing with a commonest cardiac rhythm disorder, they present to GPs, the cardiologists, emergency room, stroke medicine, internal medicine, etc. There's this almost silo-based fragmented care for patients with atrial fibrillation. So you can imagine the poor patient with atrial fibrillation sees the GP, sees internal medicine, goes to the cardiologist, they all get different messaging on how to treat. So surely our patients need a better and a streamlined, uniform approach to their management. Because after all, it's the patient pathway, whether the patient's managed in general practice, whether the patient's managed in hospital practice, whether it's managed by cardiologists and non-cardiologists, this consistent messaging is required irrespective throughout the patient journey or the patient pathway. Hence the introduction and the proposal of the ABC pathway, the atrial fibrillation better care pathway. And this, I showed earlier, was in the European guidelines as well as other guidelines globally. So A is avoiding a stroke, where the default is stroke prevention unless they're low risk. B is the patient-centered, symptom-directed decisions on rate and rhythm control. And finally, C is the cardiovascular and lifestyle and psychological risk factors associated with a patient. So you superimpose the previous slide, you see this structured pathway there, whether the patient's managed in primary care, whether the patient's managed in secondary care. Simple strategy, streamlining primary and secondary care management of patients with atrial fibrillation. So conceptually, that's all very well. Is this going to make a difference in terms of the outcomes for the patients with atrial fibrillation? Because we, as healthcare professionals, want to do the best for our patients, and we want to reduce mortality, we want to reduce bad outcomes. So if you see this meta-analysis, systematic review meta-analysis, if you are adherent to the ABC pathway, this translates to a reduction in all-cause mortality by 58%, reduction in cardiovascular death, a 45% reduction in stroke, and a 31% reduction in major bleeding by adherence or compliance with the ABC pathway. Or you could say, if you want to have evidence-based intervention, not eminence-based intervention, not a VIP-based intervention, well, this is as easy as ABC. What's the evidence supporting this? This is a prospective cohort study, Gloria AF, and I think you will see in this nearly 25,000 patients, adherence to the ABC pathway, nearly 45% reduction in death or major adverse cardiac events, reduction in death by 11%, reduction in stroke by 21%. So you could see this is prospective cohort study. What about trial data sets? This is an analysis we published, which was an ancillary analysis from the ENGAGE trial. And this is why a trial cohort, because it's adjudicated outcomes. These are patients followed up. And you will see here, adherence to the ABC pathways to the left of this vertical line, reduction in stroke, bleeding, major adverse events, net outcomes, cardiovascular hospitalization, mortality, and all-cause mortality. And that's also irrespective of warfarin or using a NOAA. So in a trial, adjudicated outcomes from the post hoc analysis of a trial. But what about a clinical trial? Well, we have this is the MAFA trial. This is the multi-morbidity subgroup. And I highlighted before how these patients are often multi-morbid. So cluster randomized trial, usual care clusters versus the intervention based on the ABC pathway. And to cut a long story short, this translates to the reduction in primary outcome of stroke, mortality, hospitalization by about 2/3. So an intervention based on the ABC pathway in a prospective cluster randomized trial leads to this improvement in outcomes. We are currently running the AFFIRMO trial. This is funded by Horizon Europe, EU grant-funded trial in multiple countries in Europe, and this is ongoing at the moment. Broadly similar design with a cluster randomized trial, the ABC pathway. So, Rector, Vice Rector, Senate, my good friend, for atrial fibrillation and stroke, I'll hopefully emphasize how common atrial fibrillation is, how it confers a large healthcare burden and cardiovascular complications. I've hopefully illustrated how risk factors don't occur in isolation. And what we're dealing with is a patient population who are clinically complex, with multiple phenotypes, with implications for outcome and their management, and risk is not static but dynamic. So how do you manage these patients? Well, stroke prevention, the default is stroke prevention unless the patient's low risk. That's the A, avoiding a stroke. Then we consider symptom management with decisions on rate and rhythm control. That's the B, better symptom control. And finally, the C, cardiovascular risk factor and comorbidity management, including lifestyle type factors. And such a simple, holistic, and integrated care approach is associated with a lower risk of clinical outcomes, rather stroke, mortality, bleeding, and hospitalization. You can say, past, present, and the future. Well, the future is probably as easy as ABC for patients with atrial fibrillation. And with that, thank you for your attention.
Dear Professor, dear Dr. Honoris Causa, many thanks for this state-of-the-art lecture. As you said, it was as easy as ABC, so thank you very much for this holistic approach to atrial fibrillation. Dziękuję wszystkim Państwu zebranym za przybycie i udział w uroczystości. Chciałem poinformować Państwa, że na moje ręce spłynęły listy gratulacyjne dla doktora honoris causa, pana profesora Gregory'ego Lipa, od ministra członka Rady Ministrów, pana doktora Michała Wójcika, jego magnificencji rektora Warszawskiego Uniwersytetu Medycznego, pana profesora Zbigniewa Gaciąga oraz jego magnificencji rektor Uniwersytetu Humanistyczno-Przyrodniczego imienia Jana Długosza w Częstochowie, pani profesor Anny Wypych-Gawrońskiej, którzy nie mogli dziś uczestniczyć w naszej uroczystości, za które bardzo dziękuję. Także bardzo dziękuję za list przewodniczącemu Narodowej Agencji Wymiany Akademickiej, panu doktorowi Dawidowi Kostępskiemu, który dotarł na moment przed wejściem na salę dzisiejszego spotkania. Informuję, że gratulacje oraz listy gratulacyjne będą przyjmowane przez szanownego pana profesora Gregory'ego Lipa w holu przed salą. Ogłaszam uroczystość nadania tytułu doktora honoris causa Śląskiego Uniwersytetu Medycznego w Katowicach za zamkniętą. Proszę o powstanie. Na zakończenie zaśpiewamy, odśpiewamy tradycyjne Gaudeamus. Bardzo proszę, chór.
Post iucundam juventutem, post forestam selectutem, nos habebit humus, nos habebit